Hey guys, welcome to another series of trainings. We're going to do 3 in a row, all having to do with neuro stuff. We're going to call it Brain Day. This is based on a presentation that I was going to give last month at Pleasant View, but they got called out on a structure fire, and so we're going to record it for them, do it live for them, but then also have it as a resource for the other agencies. So a couple of things with this talk. We're going to break it up into 3 separate videos so that people can watch it if they want the particular topic of stroke, traumatic brain injury, or seizure. I know that some of the other agencies we've covered this previously or recently. Also, we're going to put this up for just general consumption as well, and then I'm also going to tack it all together into one long video so that if somebody wants to watch it all the way through for CE credit or something like that, we can cover that as well. So there's going to be a little bit of gaps in there. There's going to be a little bit of repetition at each transition point for some stuff just for folks who are only watching that single one. And if you guys have any feedback or comments or anything else, my email is there on the cover slide. So first off, quick caveat for those who are not in one of those 3 agencies that I do medical direction for right now. Then this training is intended for agencies only under my medical direction as medical direction. Otherwise, it's strictly informational and educational. So your care of patients needs to conform to your training, local protocols, guidelines, medical direction, and your agency's SOPs and SOGs. But obviously, you're welcome to watch this for educational purposes, and I hope you get something good from it. So our goals throughout today are going to include stroke, traumatic brain injury, and seizure. So let's start off with learning goals for stroke. We want to talk a little bit about the history of stroke care and the history of stroke, discuss similarities and differences between different kinds of stroke. That includes things like ischemic stroke, hemorrhagic stroke, and heat stroke, and then also just understand pre-hospital stroke care. Now, for a scope of practice issue, the cool thing about stroke care is unless patients are so completely obtunded they need advanced airway management, which is fairly rare in stroke, then all of the stroke care really falls under BLS protocols, which is pretty cool. And that's true of the other stuff that we're going to talk about today. So obviously the history of stroke, everything, if we want to talk about history of stroke, we're going to go back in time to Hippocrates. Certainly Hippocrates talked about stroke, but obviously didn't know the pathophysiology like we do. And so there's some weirdness in stroke in that we use older terms and older concepts to describe what's going on, including the word stroke itself, which used to cover a broad set of different similar appearing presentations when people didn't really understand the difference. And so one of those, an even broader definition is this concept of apoplexy. You might see this word out there from time to time, but it's really an archaic medical word that basically means someone who has an acute loss of mental status. So they're talking to you right now and then they lose consciousness. So obviously this covers a ton of different things. This covers seizure, syncope, cardiac arrest, really, intracranial hemorrhage, ischemic or thrombotic stroke, intoxication, all kinds of different stuff. Just having the vapors and having a psychogenic syncope or something like that. All of those things fell into this concept of apoplexy. And really, what apoplexy means when you translate it into English is to be struck down. And to be struck down is where the concept of stroke comes from, or at least the term of stroke comes from. And this idea of being struck by lightning and suddenly falling down. So when we say that someone had a stroke, it's this idea of that acute change that fits into that. And specifically an acute change in neurological functioning, mental status. So again, apoplexy has been known forever as a medical problem. It includes cardiac arrest, stroke, epilepsy, massive P, etc., etc., etc. But anything that causes a sudden death or disability. In about the 1500s to 1800s, we started to understand the vascular nature of stroke and the idea that this was coming from blockages within the arteries in the brain. In the 1970s to 1980s, we developed an understanding of how to do risk mitigation for stroke. We didn't have many treatments for stroke. We were pretty good at diagnosing that after the fact, but really what damage was done was done. But we started to understand blood pressure management, cholesterol management, these things that reduced the risk of patients having a stroke, and we started to reduce the frequency of stroke. Then in 1995, we had the introduction of TPA, where we actually started to have an intervention that could possibly help improve outcome in stroke. And now most of our stroke programs in hospitals and the stroke system is based around these interventions that we have, including systemic TPA, intra-arterial TPA, where they put it straight into the brain, or physically going in and pulling out the the blood clots. So I do want to talk, when we talk about different kinds of stroke, is something that always came up to me is, why do we call heat stroke when it's clearly not anything to do with stroke per se, like we talk about? And it's this idea of this acute onset of a mental status change. And heat stroke goes back in time historically to this concept of the noon witch. So people would take lunch breaks at noon to avoid being struck by the noon witch. That would, if you had exertion in the heat of the day, could happen. And so that's where the lunch break comes from, where we have people who are trying to not be outdoors working during the heat of the day to prevent heat stroke. The Boy Scouts, if you go back and teach, and sometimes they still teach this, that the cardinal concept of heat stroke is lack of sweating. But that's actually incorrect, and a lot of people are dead because of that concept, because people who are well heat acclimatized can actually sweat through heat stroke. But if we think about the word stroke meaning to be struck down, that tells us that we're thinking about mental status, and if the patient has altered mental status, we are in play for heat stroke. A little bit different to have heat syncope, where somebody passes out from dehydration, standing up for a prolonged period of time, but immediately comes back to normal consciousness afterwards. That's a different entity. This is when someone is still confused and having mental status changes after heat exposure that's not rapidly reversing. And the reason we care about this is that heat stroke itself has up to a 75% mortality. So that's higher mortality than regular stroke does. And what they die from is usually multi-system organ failure or severe brain injury from the excessive heat. And so we want to be very, very aggressive with stroke. Especially, I'm recording this on a 96-degree day here in Denver. This is something that we're going to see more and more of in the pre-hospital setting. But let's get back to stroke when we start talking about ischemic and hemorrhagic strokes. So a hemorrhagic stroke, we have some CT scans there. This is when the patient's neurological dysfunction, which is the hallmark of stroke, is caused by bleeding. So these are intracranial hemorrhages, interparenchymal hemorrhages, or bleeding within the structure of the brain that is causing neurological dysfunction because it's pushing on those structures and making them not work. And you can see on the MRI here, you can see some of the inflammation around that big blood clot on the left side of the picture, which is the patient's right side. That's the big white thing on the CT scan. Now, an ischemic stroke is different. That's where we have a blockage to an artery that's feeding part of the brain, and all of the brain tissue downstream, because it's an end organ, dies, or at least is stunned, or eventually dies because of lack of circulation. So really two completely opposite mechanisms. One is a blood vessel bleeding, the other one is a blood vessel that's plugged up, both of which cause acute mental status changes, and therefore both are called stroke, just like heat stroke is called stroke. So those two things kind of get lumped together, and actually in our stroke processes in hospitals, those two disease processes are actually measured together, even though they have very, very different treatments. So that gets to the next question of, why do we need a CT scan so quickly in stroke? And the reason why we need a CT scan very quickly in stroke is because we really want to make sure that we're not missing a bleed, because we want to differentiate between this CT scan on the left side, which is normal and isn't showing anything, versus a CT on the right, which is showing us a large left-sided bleed. That white stuff in there is blood. Because if we think back, our intervention is TPA, which dissolves blood clots and opens up arteries. If we have a patient who's already bleeding and we give them a drug that dissolves blood clots and opens up arteries, that bleeding is going to get worse. So if we gave the patient on the right TPA, it would be likely fatal for them because it would accelerate their bleeding. So when I'm getting a CT scan in a stroke alert, I'm not looking for the stroke itself. I'm hoping the CT scan is normal, because within the treatment realm of 4 hours or even up to 24 hours for intraarterial treatment or other neurointerventional treatments, my CT scan should still look normal. That tissue shouldn't show the changes that happen when it dies until at least many hours out, usually a day out. So if I have a stroke alert that goes straight to the CT scanner, if I'm going to treat with TPA, I'm looking for a normal CT scan. If I see bleeding, I pivot out of the TPA pathway and I go into the intracranial hemorrhage pathway, which again is still tracked by the stroke programs, but it's a very different mechanism, different treatment, different goals. So in hemorrhagic stroke, our goal is directed at control of bleeding and controlling that mass effect. If there's enough blood, we actually have to remove a chunk of the skull to be able to decompress the brain. We're going to do blood pressure control to try to decrease the rate of bleeding. If they're anticoagulated, we're going to reverse those. If there's a ruptured aneurysm, they're going to either have the neurosurgeon open up and go in and clamp that, or the neurointerventionalist go up and put a little coil on the inside of that clots off the aneurysm and stops it from bleeding. And if there's extra swelling, either from the irritation of the blood or swelling from just there being more blood in the skull than the skull can handle, they'll take that chunk of skull off to allow the brain to basically expand temporarily, eventually closing that back up. And very frequently we medically manage these intracranial hemorrhages. If they're small and they don't need surgical decompression, they usually stop on their own with anticoagulant reversal. We watch them and we manage issues like seizure from the irritation of the blood. Ischemic stroke, the management is directed at opening up the blocked vessels. We'll give them aspirin. We'll allow their blood pressure to remain slightly high so that we're continuing to have a good cerebral perfusion pressure. If they're within the window, we would do TPA intravenously, or potentially later on we'll have a longer time frame where we could do our intraarterial TPA, or physically go in and remove that thrombus and do a thrombectomy. So when I'm looking at a patient who's in a stroke presentation, there's some symptoms that kind of make me point one way or the other of hemorrhagic versus ischemic. Obviously, it's not going to point me enough that I'm going to go ahead and give TPA without a CT scan, but we can get some general ideas of what we're thinking about. If I have a patient who presents with a severe headache, I think hemorrhagic stroke. Ischemic strokes are usually painless. Seizure, again, that blood inside the brain and outside of the blood vessels is very irritating to the brain and inflammatory, and it can cause seizures. Obviously, a patient who has trauma and now stroke-like symptoms, I'm going to think of a bleed. Anticoagulated patients, I'm going to favor bleed, although many patients are anticoagulated because they've had a stroke and they're high risk for stroke. So that one's a little bit of a push. Symptoms that are slowly progressing over time makes me think hemorrhagic. It makes me think of something expanding, pushing on more and more stuff. If I have someone who has profound altered mental status, that favors bleed in my mind. Although some people with a massive stroke or a large hemispheric stroke can really have some significant mental status issues. And then certainly the younger the patient, the more I think hemorrhage, because they usually have healthy blood vessels, although some people can have an inflammatory or autoimmune vasculitis or throw blood clots from paradoxical emboli because they have a little hole in their heart. Now, if I see patients who have slowly improving symptoms, that makes me think ischemic stroke. That makes me think of an artery that got blocked and is now opening up a little bit, usually painless. History of atrial fibrillation, because those patients get clots in their hearts and then throw them north up into the neurocirculation, that makes me think of that. Unilateral symptoms, certainly, I think of ischemic stroke, although a unilateral hemorrhagic stroke can do the same. Primarily speech and motor systems, because that middle cerebral artery seems to get hit very frequently, they'll present with isolated speech and motor problems. I think more ischemic stroke. And then the posterior strokes, the dizzy, clumsy, vertigo, vision changes. That makes me think posterior. So why do we get progressive symptoms in hemorrhage? It's because if that bleed keeps going, it pushes on more and more structures. Here's a CT scan that shows intracranial hemorrhage. On the left is an early CT scan, and on the right is a follow-up, and you can see that bleed is getting bigger and bigger over time. So in a hemorrhagic stroke, you start to see more and more progressive symptoms. And then why, fixed or improving symptoms of ischemia? Because there is some redundancy in the circulation in the brain. We have the circle of Willis. Circle of Willis sits at the bottom of the brain, so this is a picture of the brain from the bottom with the carotid arteries coming up there, and they basically branch off to form the middle cerebral artery, the anterior cerebral artery, and then connect to the basilar artery through this circle of Willis. So the cool thing here is if I block one carotid artery or the other, I can get flow from the opposite side. So if I throw a blood clot and it gets stuck in a big artery, I may get some redundant flow, and then also that clot may get broken down by the body itself. The body makes TPA, and slowly get smaller and move upstream to where it's blocking smaller and smaller arteries, and other parts of the brain are getting perfused again. And then the thing we want to think about are what parts of the brain get affected by these different strokes. And so the anterior cerebral artery, so this picture of the brain, the front of the patient's face is on the left, and their back is towards the right. Up and down is correct for A and B. And the first picture is looking at the brain from the outside, whereas the second picture is if we slice the brain down the middle, we're looking at the medial part of the cortex. So that bluish color, that is where the anterior cerebral artery covers. It gets some of the frontal lobes, it gets some of the stuff that sits there in the middle. The functions that are regulated by that are fairly subtle to see because it's not affecting speech, vision, or motor function. Whereas the middle cerebral artery, that yellow territory, that's going to cover on the left side the patient's speech areas and also their motor strip, which controls most of their motor function in the body. So you'll see the patients who have that typical presentation where they have speech problems. If they have a left-sided stroke, the left side of the brain feeds the right side of the body, so they'll have speech problems because their speech circuits are located on the left side for most right-handed people. And then they'll lose function of their right hand and maybe their right leg because they're losing that motor strip, and they'll have the paralysis there. The red side, pink side, is going to cover the posterior cerebral artery. That's going to cover visual cortex. So you'll have people who lose vision of half of the universe because they'll lose the vision, the processing and vision of both of their eyes on one side but not the other. They'll also potentially lose some balance issues, which is not shown here because the cerebellum is also perfused by the posterior cerebral artery. And so, if we look at this middle cerebral artery, or MCA, and again, I'm kind of dating myself with my musical tastes here, that MCA effect is what really causes those typical strokes. Now, the problem with the typical strokes is that people still can get anterior circulation and posterior circulation strokes, but because they're subtle, they frequently get missed. Because they frequently get missed, we live in this self-fulfilling prophecy that middle cerebral artery strokes with the weakness and typical speech changes are the most common strokes. It's more that they're the most common strokes that we diagnose and that we find because we frequently miss the other ones, that we were undercounting those. So thinking about that circulation pathway, that middle cerebral artery is typical, but the posterior cerebral artery circulation can also cause debilitating strokes, but has more subtle symptoms. Vertigo, clumsiness, difficulty walking, nausea, vision changes, things like that, which really can be caused by many, many things. So then if we think about our plumbing issue, and we think about hemorrhagic versus ischemic plumbing, for our hemorrhagic plumbing, or our ischemic plumbing, we're going to think of like our sprinkler lines when we get something that's choking them off. Although usually in the brain, what's choking it off is internal, it's plaque. It's arteriosclerosis and plaque, just like we get plaque in coronary arteries, that is slowly filling that up. And then if that plaque breaks open, the lipid is very inflammatory and irritating, and it forms a blood clot there. You also can get blood clots that travel from other parts of the body, specifically the heart, or potentially from DVTs. If the patient has a hole in their heart where it can cross from the right side to the left, you can get that embolic stroke where blood clots are traveling and then landing in the cerebral circulation. Versus hemorrhagic plumbing, which is like the floor is lava here. Their blood is leaking out, and it's leaking out and getting everywhere. We also want to think about things like stroke mimics. So what stuff can look like a stroke? So things like trauma or traumatic brain injury, complex migraine, overdose, hypoglycemia, DKA, sepsis. meningitis, encephalitis. Todd's paralysis, where you can have a partial paralysis and speech problems after a seizure because the area of the brain that was seizing is now stunned and not working temporarily. So people can wake up after a seizure and look like they're having stroke symptoms. Brain tumor, brain abscess. Now malingering, I'm going to put in there. We always want to be very cautious of diagnosing malingering because we're just not that good at diagnosing things. Specifically in the ED, we can still miss a lot of stuff. Definitely in the pre-hospital setting, we have no real diagnostic tests for these. So we want to be very, very careful when we're saying somebody's faking acute mental status changes. Even though, yes, I agree, they do. We want to be cautious because when you tell someone who's having an acute medical problem that you think they're faking, that really undermines not just your credibility, it actually undermines their trust in the entire medical system. So be very cautious with that. Patients who have old strokes and then decompensate for other reasons, maybe they get septic or a urinary tract infection. Multiple sclerosis can look like a stroke, a little bit slower onset. And then Bell's palsy is a very common stroke mimic where you get paralysis of the facial nerve and isolated facial paralysis, which can look a lot like a stroke. Now the cool thing about all these things that look like a stroke is my workup is the same. I'm going to look for the dangerous thing, head bleed or ischemic stroke, and I'm going to rule that out and then look for all these other things too. So that's the cool thing about the stroke alert is it's designed to be a bit of a catch-all where it's going to be very good at diagnosing stroke and it's going to be very good at diagnosing stroke mimics and treating them and supporting them. So even if patients are having a stroke mimic, they benefit from the stroke alert process because they're getting that acute rapid care and getting this other stuff evaluated and ruled, either diagnosed or ruled out. So timing of treatment. TPA needs to be given as soon as possible, but no later than 4 hours after a symptom onset. So the longer you wait, the more tissue dies and the more risk of bleeding from TPA. So over time, you have a greater and greater risk of bleeding and more of that tissue is irreversibly dead. So there's less decreasing benefit over time, increasing risk. And at 4 hours for IV TPA is where we have a crossover for the risk to the benefit, where the TPA becomes more dangerous than it becomes helpful. The intraarterial TPA, they can go out further. Thrombectomy, they can go out further. So in the hospital, we'll call a stroke alert within 24 hours of onset or 24 hours of last known normal if we can't figure out exact time of onset. Last known normal is really key because we don't want when the patient noticed that they had the stroke, we want to know when was the last time we knew they didn't have a stroke. And so we can give the intraarterial TPA up to 6 hours, maybe a little bit longer, thrombectomy 24, and so stroke alert can be called up to 24 hours of onset. We have a specific protocol at North Metro where we're using a shorter time of, we're using a bit of a shorter time in collaboration with the local hospitals up there. Certainly presenting this as what's going on, letting the hospital choose how they want to do the stroke alert and whether or not we're going emergent, that's going to be a specific discussion with each agency and each landscape and catchment area and destination stuff to take into account the risks of going emergent when we're very far out from an acute stroke. So we can talk about those things specifically agency by agency. So what is our pre-hospital stroke care? So again, the cool thing here is all pre-hospital stroke care falls within BLS scope. Because this is things anybody can do, any provider can do, which is cool. So our A, B's, and C's are important because good supportive care is key. Ischemic brain hates low blood pressure or hypoxia or hyperventilation. So we want to be very cautious with those things. We want to know the time of onset or last known normal. We want to get an accurate med list. We also want to know DNR, who is the power of attorney, who's the family contact, because we need to consent people for some of these treatments, and being able to figure out who those people are and get in touch with them quickly is very important. So if they just happen to be saying, I'm going to get to the hospital, and they show up an hour and a half later, that makes it really hard for us to use them as a to help understand what the patient would want if the patient's unable to talk to us or unable to understand what's going on. Also, the thing you guys can figure out, is there any chance this could be trauma? And so did the patient have a stroke and then fall? Did they have a fall and then bleed? Or did they have a stroke and then fall and then have a traumatic brain injury on top of their stroke? So getting that story and that picture as best you can from what you're seeing helps me out, because once the patient's on a gurney rolling into the ED, I don't have any of that context, and that can change. What am I going to look for? Am I going to add in CT cervical spine? Do I need to look for an intrathoracic or intra-abdominal injury before I give this patient something that's going to make them bleed from anywhere that bleed hard from anywhere that they're bleeding slow right now? So that helps out a ton. And what's our stroke exam? Really the very basic stroke exam is going to be looking at facial droop. It's going to be looking for if they have speech issues, and then looking for pronator drift. And so I'm going to show you pronator drift here. So if I just have someone do kind of a Frankenstein arms here, and then have them hold there like this with their eyes open, they're going to look. And if they're getting a little weak, they're going to start correcting this. So I can become more sensitive if I make the patient close their eyes, because now they can't tell if that arm is starting to drift down. I can get even more sensitive if I have them rotate their hands upwards using that pronator muscle, because it takes some work to hold your hands palm upward. And now if I close their eyes, I can see very subtle weakness in the pronator muscle, where one of those hands is going to start to lose pronation. That's the subtle thing. If they have global weakness, it's going to fall. And sometimes you can catch people who are playing little games with us where they want to fake being weak. They don't know they're supposed to pronate, and so they'll look weak by just lowering that arm with strong pronation. Now again, are there strokes that can just get this section of the arm? Sure. So we're not going to hang our hats on that and call someone a liar because of one finding. But if I'm looking for someone where I'm not really sure what's going on, there are several neuroexam findings that are difficult for people to understand unless they're been trained by a neurologist. Difficult to understand what the finding should be. And so if they're trying to fake it, they fake backwards. And so anyway, and we can talk about that later on. It doesn't really apply to our care in the pre-hospital setting. So we have our Cincinnati Pre-Hospital Stroke Scale is what we would use. There are additional stroke scales that we can add in that add a little bit of sensitivity. There are also stroke scales that will add in more sensitivity to posterior strokes, which you'll see in the other gray box on the right here. And so the Cincinnati Pre-Hospital Stroke Scale is very specific for stroke, in that if you have a positive Cincinnati Positive Stroke Scale, you're probably having a stroke. If you have a negative Cincinnati Pre-Hospital Stroke Scale, there are other strokes that can basically not show up with facial droop, pronator drift, or speech issues, mainly posterior strokes. And so those things where we have impaired balance or coordination, vision loss, headache, confusion, or altered mental status or seizure, that could be suggestive of a stroke, but certainly we get less less specificity if we include those symptoms, because we're starting to catch more and more of those stroke mimics. So that gets us through our stroke learning goals. And our next section, we're going to talk about traumatic brain injury. If you're watching these one by one, go ahead and check out the traumatic brain injury one next. If you're looking at this where it's all stuck together, we're just going to go straight into that one. And if you're going to take a quick break, this is a good time to do it.